Hello, I'm Professor Chia, Yook from Sunway University. Previously, I was at University of Malaysia, where I started programs for the Faculty of Medicine under the Department of Primary Care Medicine, stroke general practice, if you like. But recently, I joined Sunway University because I wanted to offer a program on training for postgraduate training in geriatric medicine for primary care doctors, which was launched last year, and we are in our second cohort now. That is a program that the geriatricians, the Society of Geriatric Medicine in Malaysia, as well as a country itself, felt that it's necessary because we don't have enough geriatricians. We are aging very rapidly, and we have got many health clinics where some of the care can be delivered by the doctors, the primary care doctors, with some upskilling and training in geriatric medicine. And so that's our purpose of having this program. Okay, so that's what I do now, mainly delivering the program. It's a brand new program, first of its kind, online blended learning where there's clinical attachments and these things. The first cohort took the exam and the course, and of course gave very, very positive feedback. They are more than happy with the course. And so we are going to continue offering this program to train doctors in geriatric medicine for the elderly. And of course, I do a lot of research and a lot of other activities besides my daily work of this program. I think perhaps what you're saying is not quite accurate, because depending on the country, like US has already seen the fall in cardiovascular disease, death, and mortality. Starting maybe even in the 80s, 70s, because they put in a plan and it's coming down. Malaysia has been sort of on the rise, very high. A third of our deaths is due to cardiovascular disease. But just last year, I think I see it flattening. So I think we are plateauing and we are going to fall. So this is of course based on age standardized death rates and rather than absolute rates, because absolute doesn't make sense when you have different population cohort. And so therefore we can see, well, in Malaysia it's a total death. It doesn't matter. It is seeing a fall. And so I think we are getting somewhere. Prevalence of hypertension in certain countries, particularly in the less developed countries, may be rising, and that's because it is associated with the society changes of obesity and so on and so forth. Whereas many countries, like even the US, where they have put in a lot of health policies, plans to exercise and so on and so on, it actually is not rising anymore. Malaysia has been static for quite a while. We are also running at about, depending on which age group, if we look at 30 years and above, it is more than 30, 42%. If we take 18 and above, 30. But the rise actually is the greatest in the younger age, between sort of 45 to 55, and the elderly, because we are having people living longer, and the prevalence of hypertension in those 65 and above would be 78% and above. So it is getting higher, primarily because people are living longer. Okay, so some of these patients, of course, the not so detrimental effect of it is they did not have it young, so they do not have long-standing hypertension that leads to kidney disease and so on and so forth. So they are just detected at the advanced age, which of course if we treat it, the outcome is pretty good in a way. Nevertheless, having said that, 33% of the death due to cardio is very high. So 1 in 3 people die of cardiovascular disease, and of course that's not good. So most countries, of course, because it's the leading cause of death in almost every country, whatever the economy, whether it's low, middle income, high income, even low income countries, of course, are still infectious disease, not quite there yet, because they are also going to transit to the way Malaysia and the low middle income and the other middle income countries do, from not obese, a lifestyle different to a new lifestyle that predisposes them to hypertension. So that's what's happening in the world. Of course, hypertension management, there's lots of good drugs to treat. There's no reason why people shouldn't be treated. That's very, very strong evidence for the treatment of hypertension and for its very, very good reduction in cardiovascular events. Heart failure reduced by 42% and strokes 38%. So these are fantastic reductions with just using drugs alone in that sense. And of course, if you add on lifestyle changes, it will be even better. So that's the situation now. But I see hypertension I'm not so concerned about the rising prevalence because it is inevitable. Aging and hypertension is inevitable. In fact, the lifetime risk at the age of 65, if you live for 20 to 85, the lifetime risk in that 20 years of getting hypertension is almost 100%. Means you're almost going to have, every one of you are going to have hypertension. But as I said, that the advantage, in a way, advantage if you like, is that you have it for shorter duration. So your damage to your end organs are far less if you detect it early and treat it early. Okay. To me, I see the problem, particularly in Malaysia and a lot of countries in Asia, Southeast Asia in particular, which of course has quite a big population. That would include China. I think most of the hypertensive patients will come from this region, partly because of the population size. China, India put together outnumber everybody in the world, and therefore you're going to have total numbers, absolute numbers. Great. What I notice is not so much, people talk about poor control, resistance. That is a minor problem to me. Minor. What we know is that practically 50% of those who have hypertension do not know they have hypertension. So if you treat all those who are known, no matter how well you treat it, there's this whole group, half of them, who's not treated. And this will continue to add to your death. So I think the task is to identify these people, treat them if necessary. What I noticed is when we screen, we found that the awareness started to be better. So it could be the same people being screened, doesn't matter, because these people last year didn't know, now they know they have hypertension. And that's what the level of awareness that they're trying to increase. So in my mind, I suppose one of the ways to identify all those who are unaware is to do screening. No two ways about it. So everybody has to do some form of screening. Not so much the people walk in your clinic because automatically the blood pressure is measured. It's the people out there who never reach a healthcare center, a healthcare provider. They are the ones that need screening. We all know what we mean by white coat hypertension. There's two terminologies we must get clear. One is white coat hypertension, whereas one is white coat effect. White coat hypertension is meant to define someone who has not been designated as hypertension yet. So in other words, you come to me, I measure your blood pressure, it says 160 by 100. You go home and measure it's 130 by 80. So it appears that you have white coat hypertension in the sense that in my clinic, it's high, at home, out of the office, what they call out of office measurements, it is normal. So this is what is called white coat hypertension. There's also a group that we already diagnosed as hypertension. We don't know whether they have white coat or not because it was not done. Nowadays, you are treating them. They go home, you measure in the clinic 160 by 100. They tell you when they measure home 130 by 80. This is while they're on medicine. So we call this white coat effect. It could have been white coat hypertension because it was never proven whether they had white coat hypertension before you started them on treatment. Yeah, so that is an issue we don't know at all. So although we call it white coat effect, whether it's truly because of the medication, they're truly hypertensive, but because, say for instance, before they're treated, they were 180 by 180 by 100. And when they measure at home, it was 140 by 100. That means they actually have hypertension because the home blood pressure should be 135 over 85. Then when we treat them, it comes down to 160. At home, it comes down to 125. That they'll say, white coat effect, because the difference is a lot. But they are still truly hypertensive. Yeah, they're slightly different. So because most of the patients we are treating, we never subjected them to testing at home before treat. We don't know whether they have white coat hypertension to start with, or they truly have white coat effect. That we don't know. Okay. So what white coat hypertension is, say for instance, you are trying to diagnose somebody with hypertension, you do the measurement at home and in your clinic and find it's white coat hypertension. Nobody knows the answer, whether it is dangerous or not. But there are papers that have followed up these individuals, not on treatment because people don't know what to do, or didn't want to be treated or whatever. They followed up and found that more than a third of them, will get a cardiovascular event. So therefore you got to decide, does white coat hypertension cause cardiac? I personally believe it does. One. Two is, although they don't become, some of them may not have cardiovascular event, but they will progress to develop hypertension. Common sense tells you, if my blood pressure is a bit high by the time I age a little bit more, this was a 4-year follow-up, I would get hypertension. Again, vast majority will get hypertension. So the question then is to treat or not to treat. All the clinical trials that we had, all the earlier, the very famous ESCOT trial and so on and so forth, even the sprint that was done recently, all the blood pressure measurements that were done were in the clinic. So in other words, we treat on the clinic. You may have a white coat effect. We don't know. We're still treating you. So my stand is, how do we know these people who were in the treatment were not already white coat effect, yet the benefit is there. No harm was done. You understand me? Because if we was harming, I would have more death or more events in those who were treated, but that's not the case. So therefore, I think my own conclusion is white coat effect, white coat is a risk factor. And I may decide to treat based on other cardiovascular risks. Say, for instance, they're older, they got heart disease, they got kidney disease, they already had a stroke and things like that. Particularly if the cutoff point is very arbitrary. We choose 135 over 85. What happens if my white coat effect is 134, which is just 1 millimeter short definition, but my clinic is 160? I am more inclined to treat such an individual because the white coat cutoff is so narrow. The home 134. But of course, if I measure 180 in the clinic and you measure at home it's 100, then I will be a little bit more careful. You understand? That's a huge difference. So I base all these things and then make a decision, discuss with the patient and say whether we go or do not go on treatment. And of course, I follow them up very carefully. Hopefully they will do home blood pressure, make sure they don't get postural drop, make sure it doesn't drop too much, make sure they do not have adverse effects, and start with a small dose to see. Because I'm sure even in the clinical trials, if we know white coat hypertension is 30%, they've all been treated in the ESCOT study. Yeah, because everybody who's found to fit the criteria gets treated. But we don't know the white coat hypertension patients, who they are, and they also entered the trial. So therefore, the evidence is that unless the trial can go back and look at the data and say, these individuals had white coat hypertension and they also benefited. But of course, nobody measured the home blood pressure. So therefore, we will never have that answer. Of course, clinical trials can be done now. I think some people are doing it in small numbers. But of course, it will take a long time, like in huge numbers in order to show any benefit, because the reduction of blood pressure may not be a lot. The Framingham came up with the risk score for coronary heart disease. Then many years later, they realized they need to cover strokes as well, because hypertension and stroke is more related than hypertension and heart disease. We know that when you reduce blood pressure, you reduce strokes more than heart disease. Why? Therefore, it tells you that stroke is much more blood pressure dependent. Heart disease is not as much as stroke blood pressure dependent, because they have the cholesterol problems and so on and so forth. Okay. So to me, again, I see it as this tells me that stroke has to be included when we are trying to predict risk of blood pressure to cardiovascular outcome, not just coronary heart disease. So Framingham, of course, very cleverly again went back to their data, because by that time they had the offspring cohort. They're now into their third generation cohort, bigger numbers, and they recalculated or reassigned marks, points, and came up with this, what they call general cardiovascular risk chart. And they also realized a lot of patients are already on hypertension, already on treatment for hypertension. So they also even included those on treatment, not on treatment. So that's the score I would use, because to me, it needs to include stroke, it needs to include heart disease, it needs to include heart failure, because again, the biggest contributor to heart failure is hypertension. We have validated it in patients to see whether it can predict and is accurate or not. I have validated in patients who are treated, of course, and it works. It works very well for those at high risk and those at low risk. This was also validated in the community by another author based on our national health and mobility study. So they got the parameters. 10 years later, they go and find out how many people died of cardiovascular and say it works well. And the reason why it works well is the background. To use a tool, you need to understand which were the cohort they derived this tool from. Because if you derive it from someone who's got very low risk, if you apply it to your high risk people, it doesn't work very well. Or the other way around, which is what Framingham, it was done in high risk people at that time of the height of cardiovascular. You apply to a low risk country, it will overestimate. So you need to know this sort of things. So I validated in my country. I looked at different ways. I looked at what is our background risk, Malaysia's background. It is as high as that of the original Framingham. So I think it will work. And indeed it did, both by clinical base plus the community based study. So I tend to use Framingham as something I'm familiar with. It is that I know some of the Europeans will recommend their score, SCORE, which is good. But the score only predicts death, not non-fatal. I don't want to tell a patient your chances of dying is 5%. I don't want to die because people say, oh, I die, never mind. I'm worse to have a stroke and I'm paralyzed, which is true. So I'll rather say you can have a stroke, you can have a heart attack, or you got a stroke that disables you, tell you your risk. And because it's just not death alone, the risk predicted is much higher. A 5% score risk is equivalent to a 20% risk of the Framingham. And again, people don't know and say, well, 5% is very low. That's not correct. It is only death. We know more than, well, if you have a heart attack, 1/3 of you die, the rest of you don't die. So therefore, you need to put in the non-fatal score. Okay. So that's how the Framingham. So to me, it is very good at differentiating the high risk and the low risk, which even you don't need a score, you can tell. If you have diabetes, you're age 65, you are high risk, don't even bother to score. People also use a score wrongly. They use a score when patients are already on treatment. That's not the purpose of the risk score. The risk score is to tell us what is your risk and then decide on treatment. Decide on whether you need treatment and decide on what your target should be. If someone I see is very high risk, my target blood pressure will be lower, my target HbA1c will be lower, my target cholesterol will be lower. If your risk is not so high, I may then say, okay, your target need not be that stringent. That's how I would